Good afternoon, everybody. We're so excited that you're joining ACS and FedSoc today to learn a little bit more about healthcare policy, the ACA, and the future of healthcare in America. And we have two really exciting speakers for you today that I'm going to introduce. Before I start, though, the format will be them talking for about 20 minutes each, and then audience questions, so please don't interrupt. Hopefully we save enough time to get through all your questions. Mr. Cannon is joining us today from the Cato Institute in Washington, D.C., which is a conservative policy group within the Cato.
He meant libertarian.
Libertarian, sorry. Within the Cato Institute, Mr. Cannon serves as the Director of Health Policy Studies. In that role, he's been featured on virtually every television channel you can name. He's written in every major national newsprint organization and has authored books, edited books pertaining to healthcare policy. Also, before joining the Cato Institute, he served as a domestic policy advisor with the U.S. Senate Republican Policy Committee, advising senators on health policy, among other topics. Professor Richman, you probably all know, is joining us from just down the hall, my 1L property professor. In addition to being a property professor, he has
you can stop the introduction.
Expansive scholarly expertise in healthcare policy. He's written a number of different articles, books, law review articles about the confluence of health policy and economics, and he's been called to testify before the Congressional Committee on Health Policy before. So without any further delay or taking up these speakers' time, so I'm going to turn the floor over to Mr. Cannon. Thanks a lot.
Thank you. All right, let's see. We'll have until right about then. So thank you to Shelby and the Federalist Society and to the ACS for having me here. I want to start with a little story. I was driving from the airport here in Uber. I was taking an Uber, and as we approached the campus, my Uber driver said to me, "Do you follow college basketball?" And I said, "No, not really." "Hey, but and I know that Duke just lost." And he said, "Yeah, don't mention that around here." When you get on campus, don't talk. I'm just thinking about your safety. And I said, "Yeah, but I went to UVA. I can't pass up an opportunity to make fun." He said, "I'm telling you, don't do it. They're going to hurt you." And I said, "No, that's okay. I'll tell them that, look, if they had gone to UVA, they would be used to losing. This would come much easier for them. We don't, we've had much more practice at it than you have." Hi. Oh, we're going to be doing that. Okay, great. No problem. Okay. Oh, wow. All right, so had to get in my little Duke dig there. So now that, look at me, I wore all blue, and I still have already lost the audience. So I'm going to be talking about the two sides of the Affordable Care Act and what the Republicans are now moving through the House would do to those two sides of the Affordable Care Act. But I'll start with just a brief thumbnail sketch of why I think these the problems the ACA tried to cure and why those problems exist. What are the two main problems the Affordable Care Act tries to cure? That healthcare is not affordable, and in particular, so many Americans who lack health insurance have pre-existing conditions, and so they could not get insurance either because it was affordable or insurance companies just wouldn't write policies for them. Okay, now why, from a libertarian or a perspective or a supporter of a free market healthcare system, what sort of story do market advocates tell about why this is the case? Well, it turns out that there are a lot of things that the government does that drive up the cost of healthcare and make the problem of pre-existing conditions worse. And every time the government does one of these things, they say, "Oh, what a huge problem! We need to do more stuff to fix that problem that we created or exacerbated." And it goes all the way back to 100 years ago when the government began licensing clinicians, which economists will tell you probably doesn't increase the quality of care, which it's supposed to do, but it does increase the cost of care. It goes all the way back to the 1940s when the federal government created a tax preference for employer-sponsored insurance that now has resulted in a market where 90% of people with private insurance get that insurance through an employer. This tax preference for employer-sponsored insurance favors insurance over paying for medical care directly. It favors buying health insurance through your employer rather than buying health insurance directly from an insurance company. And as a result, it causes people to demand more health insurance than they normally would, because if you're spending what it seems like your employer's money, it's not, it's your money, then you're going to be more heavily insured. And when you're more heavily insured, you pay less of the cost of the medical care you're consuming yourself at the point of consumption. And so you consume more medical care, and you're less conscious of the cost of that medical care. So we end up with more low value and wasteful medical consumption, which drives up health insurance premiums. The prices for medical care end up higher than they would be otherwise, which makes health care more affordable. And recent experiments recent experiments conducted by employers who made their enrollees more cost conscious have shown that when you make enrollees conscious of the cost of their medical care, prices plummet. I mean, the prices in our healthcare sector right now are outrageous. And in one experiment in California, the patients who are getting hip and knee replacements, just by making them cost conscious, those patients drove down the price, the average price for a hip and knee replacement at high cost hospitals by $16,000, or a 37% reduction. Okay, that doesn't excite you. Imagine the price of a BMW fell by $16,000. You know, for budding JDs, that'd be pretty exciting. But I think the worst part of the employer-based health insurance system is this: it's tied to your job, and so people lose their coverage when they turn 18 and they leave their parents' coverage, or now when they turn 26, or when they turn 65. They lose their coverage when they change jobs, when their employer drops their coverage, when the plant closes, when a spouse dies, when you divorce your spouse. Employer-sponsored coverage disappears for all sorts of reasons that coverage purchased directly from an insurance company does not, and it often disappears after people get an expensive medical condition. So most of the time when you hear about people with pre-existing conditions, I don't know if I can say most of the time, but it may be most of the time that those people had health insurance, then got, through an employer, then got sick and lost that health insurance. This is another one of these things that the government has done to make, to exacerbate those problems of affordability and pre-existing conditions. And that's a problem that the ACA was trying to solve, one that the government was exacerbating. And as an example of, another example of this sort of phenomenon of government trying to fix problems that the government itself created. Why do you suppose, everyone knows what the Medicare program is? Provides medical care to the elderly and disabled, people over age 65. You work 10 years paying payroll taxes, you qualify for Medicare. It was enacted in 1965. It was enacted 20 years after the government created this tax preference for employer-sponsored health insurance that favors the kind of health insurance that disappears when you turn what age? 65. And so then the government looked around and said, oh my gosh, look at all these 65-year-olds without health insurance. We got to create a program for them. So, but what does the ACA try to do about this problem of pre-existing conditions? Well, imagine there are 5 kinds of people in the world. A, B, C, D, and E. And let's say that this graph shows what their expected medical expenses are, okay? We're arranging people according to what their expected medical expenses are. Expected medical expenses. And over here, the really sick people, they've got high expected medical expenses. Here, healthy people, most of them aren't going to use medical care at all in a given year. Some will get hit by a bus, averages out to right here. In a competitive market, this is the premium that insurers will charge for people in Group A, because that's how much it costs to insure them. That's how much medical care they're going to use on average in a given year. If an insurance company tries to charge them more than that, and a competitor comes in and charges them a premium that corresponds to their actuarial risk, what we call an actuarially fair premium. The problem Obamacare was trying to address is that a lot of these people over here are really sick, they got really expensive medical conditions, and they can't afford these premiums, or maybe the insurer won't even charge them, or won't even quote them a premium, because they figure that this person is already sick, and you can't insure against a loss that has already happened, much like you can't sell fire insurance to someone after their house is already burned down. Doesn't mean you don't subsidize you. It doesn't mean you don't help your neighbor build their house again, but insurance is not the way to do it. And so how did the ACA try to solve this problem? Anyone know? Yes, sir.
Community rating?
Community rating. God bless you. So we'll assume for the moment here that everyone here is the same age, just to simplify the analysis. If we assume that these are people with different ages, I just have to draw a line with an actual slope. But as it is, if we assume that everyone is the same age, what the ACA said is that insurance companies have to charge everybody of a given age the same premium. We'll call that this average premium. Now, you've heard of some of the effects of this change. What does that do to the people who, the healthy people whose premium would otherwise be this low? Their premium rises a lot, right? In order to bring down premiums for people over here, make insurance affordable for them. But that also creates some perverse incentives over here, because at the same time you're jacking up the premiums for people in groups A, B, and C, you're telling the insurance companies what? That you have to cover everyone who comes, and you can't charge sick people a higher premium than anyone else. So you've created a huge incentive for people in groups A, B, and C not to buy insurance, just to wait until they get sick, until they end up in groups D and E, and then buy coverage, because the insurance company can't charge them any more than anyone else. It makes it in their financial interest not to join a health insurance pool and make premium contributions that pay the medical bills of strangers. So the ACA couldn't just, they decided not just to do community rating, they also slapped what on everybody in the market? Yes? The individual mandate to try to force these low risks to buy this overpriced coverage. Overpriced meaning more than their actuarial risk. And so, but they didn't stop there, because a lot of folks, just telling people they have to buy coverage at this premium, telling them they'll penalize you, we'll penalize you unless you pay this premium to an insurance company, doesn't mean these people have the money to do that. And so the ACA also includes subsidies for people who buy health insurance and have low incomes. And here we're talking about, I should have mentioned this before, we're talking about that 10 or 15% of the market that's not, of the private market that's not the employer-sponsored market. This actually kind of happens in the employer market already. It's already sort of community rated. But here we're talking about the so-called individual market. So, so we've talked about the three main pillars of the ACA's overhaul of private health insurance: community rating, the individual mandate, and premium subsidies, okay? 90% of economics, because if we didn't, and this is important, if we didn't require these folks to buy health insurance, what would happen? They wouldn't buy health insurance. They would leave the insurance pool. The average risk in the pool would rise. The community rated premium would rise. And then even more of these people in groups A, B, and C would decide, hey, this is not a good deal for us. And they would drop out of the pool. The average risk in the community rated premium would rise again, to the point where maybe the market collapses, okay? So, and in fact, that has happened in, anyone here from Tennessee? I'm gonna do a really bad job of drawing your state, if you are. This has happened in about 16 counties in East Tennessee. Despite all these measures and some additional measures to try to stabilize the market after introducing community rating, in 16 counties in East Tennessee, the last insurance company in the exchange has said, we're out. In 2018, we're not selling plans in the exchange anymore. So we have an adverse selection death spiral, as the economists and actuaries call it, that's leaving 43,000 people in East Tennessee with no coverage options for next year, okay? This is one of the reasons that critics of the ACA think that this is not a good model. Another reason is because of some, we talked about some of the incentives community rating creates over here. It also creates some interesting incentives for on this side of the graph with regard to the high-cost patients. And I'm talking about incentives for insurance companies. Anyone want to take a crack at what incentives the ACA creates for insurance companies? Well, 90% of economics is asking, and then what? Yes?
Lower tax rates?
Lower tax. Is that an incentive for an insurance company?
Well,
So an insurance company knows that, okay, people in Group E are going to cost them this much, but they're only going to get a premium, they're only going to get this much premium from them. That means that for every one of these folks they enroll, they take a huge loss, right? Even if they have all these people enrolling over here, each individual Group E enrollee is a loss to them. So what incentive does that create? Yes, sir? To not enroll E's, right. So how might they do that?
Not advertise towards those people?
Yes, not advertise toward them. The Federal Employees Health Benefits Program is an exchange like the ACA exchange. The community rating is even tighter. And during the open enrollment period, because you need an open enrollment period if you have community rating, you'll see all sorts of ads around Washington, D.C. for all these health plans. But do you see people in wheelchairs in these ads? No, you see healthy, happy people with nice white teeth. Because those are the people that the insurance companies want to attract in a community rated setting. But there are other things they can do other than marketing themselves only to healthy people, not to sick people. It's a really obvious one. If you're a patient with MS, which health insurance plan do you want to enroll in? None of you have MS, I guess. Yes? Low deductibles, low co-pays, no out-of-pocket maximum, great coverage for MS, right. And the patients with MS are going to look around to see which plan has the best coverage. And whichever plan has the best coverage for MS is going to enroll the most MS patients. And that plan is going to suffer all of these losses. So many of these losses. Why? Because they offer great coverage to patients with MS. Now, the authors of the ACA knew about this. They knew that the community rating creates a penalty on quality coverage. So they created additional subsidies to try to get more money to these insurance companies that enrolled all these high-cost patients. But it turned out, and there's empirical research on the exchanges that shows that, generally speaking, patients with MS cost ACA plans, on average, $61,000. But even after you account for all the premiums and all of the additional subsidies that the ACA tries to throw at plans that enroll MS patients, they're still only getting $47,000 per enrollee. Okay? So that means it's a penalty of what? $14,000 per MS patient. And what are the insurance companies doing? Well, some of them are folding and leaving the market under the weight of these sorts of penalties, these sorts of losses. We've seen an exodus of insurers from exchanges across the country such that now there's 1,000 counties in the United States where there's only one insurer left in the exchange. There are about 2.8 million people enrolled in those exchanges. So there's 2.8 million people who are just one more insurer exit away from being in the same position as these 43,000 people in East Tennessee. And so the other way that insurance companies are responding is how? I bet you know. Yeah, if they don't leave the market, they got to do what? Well, that'd be nice, but they.
Well, if they're not lowering the quality of coverage.
That's exactly what they do. Yes, they're lowering the quality of coverage, making sure that their coverage, their MS coverage is worse than the next guy's. Because if they make their MS coverage worse than the next guy's, then all the MS patients will flock to whichever insurer does have the best coverage. I was explaining this to a U.S. senator he said, like a swarm of locusts, they'll flock to it. And I said, yes, and his staff was going, no, do not say that. But those are the sort of perverse incentives that we're creating here. So and it happens every year. You know, if insurance company X makes their coverage worse than insurance company Y, then what does insurance company Y do? They get hit with all the penalties, quality coverage, and then they either fall out of the market or they get with the program and make their coverage worse. And we get a race to the bottom. We get a downward spiral in coverage that really ends ultimately here with the market collapsing. So what does the Republican plan do about this? Well, not much. They don't really change much. They say that they're repealing and replacing the ACA, but they're not doing much to change what happens here. I did say before that we were looking at everybody within a given age, all right? And if we were going to look at people across all ages, then we need a different slope for this community-rated premium line. It would look more like that, okay? And what the Republicans propose to do is not to eliminate this community rating feature of the ACA, but really just to make it a little less binding. Should have used different colors there, huh? Right, so they would allow insurance companies, it's right here. This is a 3-to-1 age rating band that allows the premiums to vary somewhat with age, and this one would be a 5-to-1. It means that under the ACA, insurance companies can charge 64-year-olds 3 times what they charge 19-year-olds. And under the Republican plan, they could charge them 5 times what they charge 19-year-olds. But the actual average expected medical expenses for 64-year-olds is like 7 times higher than for 19-year-olds. So it's still a binding price control, but it doesn't really change the sorts of dynamics that we've been talking about. You still have essentially the same sort of regulatory structure. That's why people call the Republican plan Obamacare light. There are also subsidies in the Republican plan to help people afford coverage, but the subsidies, instead of being focused just on people with low incomes, the subsidies are tied to age. So your subsidies get bigger as you age. Now, that can be good if you are a high-income older person, but it's bad if you're a low-income older person because you don't get as generous a subsidy. People ask, why did they do that? Why would Republicans do that? And the answer, I think, is pretty straightforward. It's because older people vote more than poor people do. And they're hoping to court the votes of older people. But it still doesn't do anything to sort of to try to remedy the inherent instability that exists in a market like this. I'm already at 20 minutes, and I haven't even talked about Medicaid. So why don't I stop and let Professor Richman go, and then maybe if you have questions about the Medicaid part of the ACA and what the Republicans would do with that, we can talk about that. Thanks.
So, I don't have a whole lot to say.
All right,
in response
and
to
I'll
that.
keep going.
I think what I'll do is I'll make just 5 minutes of comments, and then Michael, you can go on to stuff where we might disagree, because I don't think really you have a whole lot to disagree about right now. I'll say two things really quick.
Made a libertarian out of him.
Well, that's actually where I'm going to start. Michael said 2 things in the beginning. One totally warmed my heart, and the second is really where our disagreement will come from. The thing that totally warmed my heart, he talked about 2 core problems to the healthcare sector. And you probably didn't even catch it, but these are the 2 core problems with America's healthcare policy. Number 1, he talked about the tax exclusion. When employers pay for employees' health insurance premiums, and usually they pay about 75%, that is not taxed. And because of that, we not only have an employment-based system, but we also have a subsidy, and we get more and more generous health insurance, and individuals don't know that it's coming right out of their pocket. He said this was a government problem that started in the 1940s, and it basically it's a result of an IRS tax ruling. And the second thing he said was the biggest problem was the creation of professional licensure. Basically, you can only get health care from individuals who are recognized by the state as a health care provider. Now, both of these are at the core of what's problematic in this country. We have insurance subsidies through a tax exclusion. Basically, the government gives us a tax break whenever we purchase insurance, which means we purchase more and more generous insurance. And that has been the fuel, as much as anything, to why we have really, really expensive health care, why we invest in high technologies for things that have fairly minimal impact on health, and why we spend about 17 to 18% of GDP on health care, whereas the OECD average is around 10%. And by the way, they're healthier than us. And the professional licensure problem means that we have a system that is controlled by providers, by physicians, by hospitals. And it is very easy for them to promote procedures that are very expensive, that they have exclusive control over, and very easy for them to stamp out competitors, alternatives, lower cost providers. Now, those are two things you haven't really heard about in any of the current debate. To the degree that those of you have heard about a Cadillac tax, that was an effort to roll back the tax exclusion, and has been an effort to roll back the tax exclusion. And before it sounds like I'm going to praise the Democrats too much for having an effort to roll back this tax exclusion, I will say that when John McCain in the 2008 election said, he basically promoted advanced a policy that was like the Cadillac tax, and Barack Obama criticized him for it. So this is something that bold politicians have advanced and have roundly been vilified for. But here's where Michael and I disagree. It's not in what we think the problems are, at least not yet, and it's not in where we think the proposals or the solutions are, although that's really where I want to give Michael some more time to talk about solutions. It's the way we present ourselves. In the very beginning, Michael said, I am a libertarian, I speak for a libertarian organization, I am taking the libertarian approach to this. We have to have sympathy for why he does it and why he needs to do that. He's got a tough job. It's like Sean Spicer. You can't blame him for the position he's in.
Watch it.
Yeah, I'm telling you, like the poor guy is told what he has to say before he gets a chance to say it. I have a luxury of being an academic. I can have a fidelity to pragmatism. I can just try to figure out what works without thinking about my ideological pre-commitments. I can look at data and figure out what works and what doesn't work. I can change my mind. I can say, hey, look, it turns out that doesn't work so well. Let's try something else. Those are extraordinary luxuries to have, and it's something that very few people in Washington have. So we should feel sympathetic for those who kind of have to say stuff because it's their job. So I think libertarians have lots of great things to say, and I think that they're wrong on a couple of things because I think the evidence shows it. I think that to some degree the Flexner Report, which was it's something that all medical students learn about, that was the start of professional licensure in the 1920s. It was a response to a truly dysfunctional health market. The best way to kill yourself is to go see a doctor in the 1920s. The Flexner Report with some kind of professional licensure requirement fixed that. To the degree that we have to figure out how to solve this problem, and this is the problem. The problem is how expensive it is to cure or to treat, and we're not even really curing, to treat expensive patients. We've got to approach it pragmatically. Ideology is not going to get us there. It's just not. And to the degree that Michael and I and people who understand how risk rating works and understand how insurance markets work, and especially understand where the costs of healthcare come from, then we can start solving the problem. So I invite Michael, stripping his libertarian burdens, to talk about us in a pragmatic way and tell us maybe what we can do to come up with some solutions. I'm more likely than not to agree with them, and then maybe we can begin some real sensible healthcare policy right here.
Okay, thank you, Professor. I am so glad to be in a place, academia, where there's no ideological rigidity whatsoever. Okay. And where they only care about evidence. All right. So, if the question and the challenge is, okay, Cannon, what would you do? Well, I would want to focus on what works. I would want to get rid of ideology and focus on what is going to make healthcare better and more affordable and more secure for people. Ideology be damned. As it happens, I arrived at my ideology after being a social democrat and after then being a conservative because my read of the evidence is that when you have a free society and when you use markets in order to allocate goods and services and to discover new ways of delivering goods and services, that is what brought mankind up out of the caves and led to the great explosion in wealth that we've seen over the last 200 years, and just about, although I have an open mind, all of the innovations that have made healthcare better and more affordable and more secure to date. So, but I think that Professor Richman and I are in agreement about so much, and I want to illustrate one of the things that we're probably in agreement about, you know, if he cares about evidence as much as he says. All right, here it is. So, if you look at healthcare spending in the United States, and this is a particular perspective I want to take, a particular way of looking at healthcare spending in the United States. I don't want to just talk about money as it reaches the healthcare providers, okay? Because it can pass through a lot of channels within the healthcare sector before it gets there. I want to look at money right at the moment it enters the healthcare sector, okay? And where it's coming from when it enters the healthcare sector. And it turns out that about 51% of healthcare spending in the United States comes from government, all right? About 21%.
And by the way, that doesn't include the lost tax revenue from the health exclusion, so it could be even more.
Well, but lost revenue is not spending. It's just money you're not taking in. That's like saying I'm doing.
That's an ideological spin.
No.
A tax cut is not spending money.
Professor Richman is making the claim that by not taking your money, I'm spending your money. Or like by not hitting you in the face, I'm doing you a favor. So
you're hitting everybody else except for this one guy.
So I'm doing you a favor by not hitting you in the face.
It's a tax subsidy.
Okay. It is a preference, a tax preference that has many similarities to a subsidy. But a subsidy is when you rob Peter to pay Paul. When you don't rob Peter, that's not a subsidy. So anyway,
it's called your spending without on a deficit.
And here's the really perverse part of this ideology that Professor Richman is peddling today. If you adopt that definition,
it's economic logic.
If you adopt that logic, then if we are not taxing employer-sponsored insurance and that's spending, then cutting that spending means what?
Tax increase.
Yes. A tax increase, a spending cut is actually a tax increase, and that's the moment where logic goes out the door.
No, that's the moment where the semantics are totally useless.
The semantics are totally useless.
The whole point about tax cut, tax increase, it doesn't matter. The whole point is that you don't tax this when you tax everything else.
Right, and that's bad, but it's not a subsidy. So anyway, moving on to where the money comes from.
It means you're taxing everything else. It's an economic distortion.
It's a distortion. It's a tax preference. It's dumb. It has many of the same effects as a subsidy, but it's not a subsidy. So, employers account for 21% of health spending because of the tax preference for employer-paid premiums. Okay. Interestingly, this money that the employers use to spend to purchase health care for you, if you have it through, or for your parents, if you have coverage through an employer, comes from Professor Richman. Who?
From you, the employee.
From you, the employee. A lot of people think, oh, this is a gift from your employer. It comes out of profits. No, it comes out of wages. So for a typical family plan, the employer is, I got that wrong. The employer is contributing $13,000 this year. Okay? That means that if you have the typical employer family plan and your salary is $56,000, which is median family income, actually your compensation is $6,900 or $69,000, but because of this tax preference for employer-sponsored insurance, you don't get to control this part. Your employer does. If you want to control it, you would have to pay taxes on it, maybe $4,000 worth of taxes, a nice little penalty on people who want to control their own healthcare spending. And that's why employers control about $700 billion of healthcare spending in the U.S. because the government imposes this essentially, depends on your marginal tax rate, penalty on people who want to control their own healthcare dollars. But then, let's see, over here we've got out-of-pocket spending where consumers give money directly from the consumer to the hospital or the doctor or the provider. And then over here, I forget what the split was. It was like, this is another 20%. This is consumer paid premiums. And I think this was 20. Well, how's my math? Because I really only remembered what those three were, and I think this was 20. And that should be enough to get me. So that was 8. That's, no. I'm sorry, that was not 20. That was 10. That was 10. So that was 10. So it was 80, 81, 92. And so this was 8. Was something like 8% was other. Private charity and stuff like that. You notice something about this. Oh, and so there's a penalty involved here that gives employers control over this money. And it used to be that some of this stuff, the premiums that consumers were paying to insurance companies, and this includes the employee contribution to employer coverage, as well as when employees pay the entire premium. Some of this used to be voluntary, but now that we got a mandate, it's kind of not, and so there's a penalty if you don't spend your money here the way the government wants. If you look at it, here we've got people spending other people's money. Here, we got people spending other people's money. Even now here, we've got people spending other people's money, or the government telling us to spend our own money the way we want instead of us spending it to our priorities. People spending their own money on medical care accounts for just 11 cents on the dollar. But consumers don't have a whole lot of control even. I wouldn't say they have even 11% control, because oftentimes this is just being spent under terms dictated by everyone else in this pie chart. But this illustrates what we call the third-party payer problem, which is that when people are spending other people's money, they don't spend it as carefully as they spend their own. And that experiment that I mentioned, where when consumers were more cost-conscious and paying for hip and knee replacements themselves and drove down the prices by $37,000, 37% and $16,000 on average per procedure, that was not an isolated experiment. There have been a number of experiments, and consumers have driven down prices for cataract removal, lab tests, colonoscopies, knee and shoulder arthroscopy, MRIs, CT scans, and so forth. Those prices fall because consumers have an incentive to ask for price information, to shop around, and to demand lower prices and go to the providers that provide lower prices. If what you want are the sort of falling prices that we've seen in those experiments, and that should be what you want, because falling prices are the most important form of assistance we can provide to vulnerable people, okay? Because it means there are fewer vulnerable people. If falling prices is what you want, then you want to solve this third-party payer problem. You don't want people spending other people's money on health insurance, and then on health care. You want the consumer to control the money, the consumer to purchase their own health insurance, to have an incentive to buy economical insurance policies, which then translated to incentive to be more economical about medical care, what they consume, what they don't consume, and sort of prices and incentives to put downward pressure on prices. And you need different solutions for these different areas. But for right here, what you need to do is to get this money, this $700 billion back to the consumers who earned it, you need to change the tax code. And there are a number of ways you could do that. The Cadillac tax is sort of an effort to try to mitigate the problems here, but it wouldn't move that $700 billion to the consumer who earns it, who earned it. To move that to them, you could just eliminate all tax preferences for medical care. Now, that would be a tax increase, not a spending cut. But even as a libertarian, I might be willing to do that. For one thing, we're running deficits, and so it's spending that determines the size of government, not tax revenues, and so it wouldn't increase the size of government to eliminate that tax preference for employer-sponsored insurance. It might reduce it. But that's politically problematic if you just tell 160 million Americans in employer-based plans, ha, there goes that tax break, we're taking more of your money. That $13,000 would eventually make its way to the workers, but in a competitive labor market, it takes time and it will only happen over the long term. I think there's a way to change the tax preference for employer-sponsored insurance, change it from a tax preference for employer-paid premiums to a tax preference for contributions into a health savings account. If you do that and increase the contribution limits on tax-free health savings accounts to the point that you could put all $13,000 into the account, then what happens is the employers go, well, if we want to retain our employees, we got to give them that $13,000, and then they put it in their health savings account, and then you let them purchase insurance tax-free either from their employer or from someone else, from an insurance company directly. And then people would be able to buy health insurance that doesn't disappear when they lose their job or turn 18 or turn 65 or divorce or a spouse dies. More secure coverage that protects them from pre-existing conditions, but also they're going to be more conscious about the cost of medical care. And we'll get to see the falling prices across the healthcare sector that we've seen in these experiments that I've mentioned. Over here, let's say you've got a bunch of different government programs here: Medicare, Medicaid, the Veterans Health Administration, Indian Health Service, and so forth. The two big ones are Medicare and Medicaid. The way you solve the third-party payer problem in the Medicare program is I like to say, don't voucherize Medicare, Social Securitize it. The Social Security program gives seniors what? A check. Gives them cash. Gives them money. Does the Social Security program tell seniors where they have to buy groceries, where they have to live, where they can, the social, to which golf courses greens fees their Social Security check may be applied? No. They trust seniors to spend that money themselves. And the Medicare program should do the same thing and instead of giving seniors a government-defined package of benefits and dictating the prices for all the services that Medicare covers and distorting the market that way, should just cut seniors a check. Give low-income seniors and sicker seniors bigger checks so that they can afford a standard package of benefits, trust them to spend the money, and we'll see the same sort of downward pressure on prices in that segment of the market. And that is the most important thing you can do for the people in the Medicaid program. The Medicaid program is the other big federal program, ostensibly just for people who can't afford medical care. And you drive prices down and fewer people will need a program like Medicaid. You can still have a program like Medicaid, but it'll need to be a much smaller program because so many more people will be able to afford medical care themselves. So that's my short answer to the question of what would an evidence-loving libertarian do in health policy?
Well, it's only slightly different from what an evidence-loving scholar in healthcare policy would want. So there are a couple. So this is classic consumer-directed healthcare. A lot of which I strongly agree with. A lot of which I've written about in a very supportive way. I'm going to talk about make three observations. Number one, the pie chart has nothing to do with Obamacare. It talks about the employer-based market, which Michael's exactly right. That's about 80% of all private insurance are employer-based, 85%. So two things. On one hand, if you're really trying to talk about the big problems or solutions to the big problems, he's talking about the right stuff. If you're talking about criticisms of Obamacare, he's not talking about it at all. Number two, the $13,000 figure there is a really important figure. That is the money that comes out of your pocket when you get insurance from your employer, but you don't know you're spending it. Basically, you're buying a new car every year and you don't know it. Interestingly, Obamacare, in a fairly backdoor sort of way, wanted to address that. Said, all right, we want to make everybody realize how much they are spending every year on health insurance. Now, when everybody complained about how expensive Obamacare is, they're just complaining about the cost of health insurance. The Obamacare plans really weren't all that different from, as far as cost goes, from the plans that were being offered through the employer. It's just that for the first time, people saw how expensive it was. I actually said the day before the exchanges went on, people are going to get sticker shock. And they did, but they thought it was the government's fault, when really this is just the cost of health insurance. So to the degree that we're trying to make people aware of how expensive health insurance is, it's a really important thing. Obamacare, you might say, helped that. But that's not where the health savings account proposal, that's not the problem that the HSAs address, and it's not the problem that the Ryan Care addresses either. Here's the real thing. Actually, I guess there are two real things. Number three, the real problem is number E, the person who's really expensive. Actually, this relates to the real thing. So I'll just say, what is it? How do we address the real costs of healthcare? How do we address the costs of taking care of people who are really sick? The proposal that comes from the Ryan community and comes from what Michael was describing is, well, if you give people a check, then that will bring the prices down. For some things, it certainly will. And the knee replacement study that he talked about in reference pricing in California, it's true. It's a terrific policy. It's a terrific idea. If you either pin co-payments or maybe even the total cost of care to actual options that are out there, and you make it reasonably transparent to consumers that the quality is comparable, you will see some real flocking towards lower cost alternatives. That would be terrific. But it presupposes that there are lower cost alternatives. Are there any lower cost alternatives to the MS patient who has a $61,000 bill? Are there? I mean, I think the answer is yes, there can be, but there aren't right now. So this is the main point. We can give people incentives to purchase lower cost insurance and lower cost care. That is only going to work if there are alternatives to lower cost care. If there's no alternatives to lower cost care, there's no going to be lower cost insurance. What do we do about the MS person? I think there are two things that you can do, and Michael, I'm afraid to say, they require some significant government intervention. One thing you can do is really try to figure out how to bring the cost of drugs down. One favorite way of bringing the cost of drugs down is to speed up the regulatory process so there are alternatives. So basically, even if a drug has a 20-year patent life, or effectively is closer to a 13-year patent life, if you speed up different drugs that have the same pharmacological qualities, then maybe you have price alternatives to drugs. That's possible. What you're really going to need, though, is figure out how to make sure that drugs in the United States cost relatively the same amount they cost in Europe. And that's totally a regulated problem. Problem of regulation, solution of regulation. The other thing you need to do, and this maybe gets to part of what Michael had hinted at in the beginning when he said he didn't like the professional licensure regime, we got to figure out how to get those 43,000 patients some access. That's not an insurance problem. That's a delivery problem. We got to make sure that there's more than one regional hospital. And in Appalachia in general, both in western North Carolina and eastern Tennessee, you have only single regional hospitals, and they have monopoly over all the docs. Well, I've been arguing for a long time that you need to have much more vigorous antitrust enforcement to prevent hospital mergers. That also requires a government. You might also need to prevent doctors from teaming up with docs and making sure that they control all access to health care. That also is going to require some government intervention. You also should, and I think Michael would strongly agree with this, have to figure out how to expand the possibilities of providing health care, either through telemedicine, through non-traditional medical providers, through behavioral therapists. This also is going to require some changes in the law. The big elephant in the room is Social Security, is Medicare. You call it a Freudian slip. It is Medicare. And Paul Ryan has frequently said that he wants to, you might say, securitize Medicare, basically give people a check. And that would involve some significant economizing behavior, which is a good thing. I don't mean to totally lambast the idea. But the reason healthcare costs are going up is not because of this third-party problem. Well, that's a significant problem. It's because of monopoly power, drugs, hospitals, doctors. That's why the costs of care are really high. That's why if you have MS, there just aren't a whole lot of ways you can economize. So what do you do when, and we're not just talking about the people who have MS, we're talking about just regular patients, regular seniors. What happens when you give them a check that just doesn't buy the health care that their doctor says they need? What do you do? Now, the answer is not, well, you just give them all the money they need. But I think it's an inadequate answer to say you just use whatever money you have. It's interesting. Medicare did a little bit to improve the health for the elderly. It made remarkable strides in solving elderly poverty, even with Social Security. In the 1960s, we had a huge national problem with elderly poverty. They were spending all of their money on health care. They had no money for food. Now, you might say this is a really bad way of solving the elderly poverty problem. That's probably true. But unless smart people like Michael focus on that E and focus on the 43,000 and stop worrying about all of these gimmicks with the insurance market, we're going to have that problem.
As it happens, I'm laser focused on the people in E, but we're short on time. You probably have questions, so yes, sir.
So I generally agree that free market's probably more efficient way to do things, whether it's a carbon tax or